This is the welcome back. I'm going to go through some Haempath cases again this week, as I do generally each second week. But between the winter school, a break, and then my leave, I've not been able to do so for a few weeks. So I've a number of cases that my colleagues have put aside for me. And I've got some of my own that I've been reporting over the last couple of days. So I'll go through them. They're a bit of a mixed bag as normal, but hopefully they are instructive. So I have to try and reorientate myself with all the technology. So the first case is this? Yeah. Okay. So I've got probably about 10 cases to go through. I might not get them all done. So the first case, if I just, I believe I'm sharing the screen. Yeah.
Yep, you are, yeah.
Yep. So let's get the auto white in place. Okay. So the first case is, it's very difficult to just move this across. I have to go to there. And no, I mean, that's into there. That. Okay. Make that smaller. Right. So the first case is a 59-year-old man who presented with anemia and some bone pain and a raised lactate dehydrogenase. The lactate dehydrogenase was 1,968. His hemoglobin was 83. White cells 9.2. Platelets also reduced 43. So this was the marrow. So we've got a decent core, probably about 1, 2, 3, 4, 5, 6, 7, 7 spaces. Let's give it a bit of a wipe, clean it. And looking down this end here, there's some slightly thickened bone here. There's also quite a lot of marrow edema and focal marrow necrosis in this area here. So it's got necrotic marrow here. Interestingly, the bone is not only thickened in places, but it's also the bone is sclerotic, is necrotic in places. So a lot of these little Auschwitz lacunae haven't got nuclei in them. So you can quite often lose 1 or 2 nuclei just because of cross-cutting, but you see in this area here, all of this bony segment here, all of these little lacunae have not got nuclei in. So this is necrotic bone. It's got some necrotic bone marrow, some necrotic bone, and then a very fibrotic bone marrow with not a lot of hematopoietic cells in it. And then this area here, I think, is characteristic. And what we have here is metastatic carcinoma. They did some additional immunohistochemistry, and these cells here were positive for cytokeratin markers, so for A1/A3, for cytokeratin 7, cytokeratin 20, and there was also positivity for CDX2. So it was considered to be a likely pancreatobiliary primary on that basis. So very bizarre tumor cells, I think in common. So if you see a fibrotic marrow, obviously the only things that cause fibrosis really are, very dense fibrosis, or either myelofibrosis or metastatic carcinoma. So in this instance, metastatic carcinoma. I haven't got the immunos to show for this case. They've gone somewhere else. I don't know where in the filing system, but um, we've got malignant cells both in the stroma and also here in the sinusoids of the marrow. And there's more metastatic tumor, and there's tumor within the sinusoids as well. So, an unfortunate case. Don't often see pancreatobiliary metastasis to the bone marrow. But I guess usually the bone marrow isn't biopsied in those patients because they usually have other symptoms which give rise to the diagnosis. Because it's usually widespread at presentation, pancreatobiliary lesions. It's usually obvious from other imaging and clinical history as to what the primary diagnosis is, and the marrow is not usually therefore biopsied, though in this case it was because of the relative cytopenia, particularly in the erythroid and platelet series. I don't think there's anything else to say about that, really, about that case. Then we've got any comments or want to ask any questions about it? Like I say, my colleagues have just given me this part of cases, so I'm not as familiar with them as I am of my own. But the key features here, we've got some bone necrosis, bone sclerosis, necrotic bone marrow down here, and then this area of metastatic carcinoma. So if you see fibrosis in the bone marrow, it's going to be one of two things, myelofibrosis or metastatic carcinoma. Okay, I'll go to the next case. So, what's it waited? Okay, this is a 77-year-old woman, and she has presented. She had a myeloid sarcoma in September 2020. That resolved on treatment with venetoclax and azacitidine. She then went on EPO, and she had a recurrence of her anemia in June 2022. And later that year, in November 2022, a diagnosis of myelodysplasia was made. Now she has got a relative, well, she's anemic and low platelets, so hemoglobin 76, platelets 92. Neutrophils aren't too bad, 4.4. And the aspirate was suboptimal. So it's all down to the trophine. So again, 77-year-old woman. So focally, the trabeculae, I think, are a little bit thinned, in keeping with her age. And the cellularity for her age is increased. We've got some filling in of the marrow spaces focally, with loss of fat spaces, like in this area here, this area here. So I think for a 77-year-old woman, it's not it's not markedly hypercellular, but it is, I think, hypercellular, particularly as we've got peripheral cytopenias. And in quite a lot of areas, we've lost the paratrabecular fat spaces, so that's abnormal. Along here, 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 and here. So we lost, even though there may not be as high cellularity in these areas as you might think in what this turns out to be, which is myelodysplasia, we've definitely got abnormal proliferation of the cells next to the trabeculae in much of the marrow. So at higher power, we've got good myeloid proliferation, and there is also some eosinophilia here. To see. Erythroid islands are relatively scanty. I think the erythroid has been markedly disrupted, so you've got lots of these small dark cells, but they're not forming erythroid islands. The myelopoiesis is left shifted, so we've got large cells like this here and these here. That's a plasma cell, but large myeloid cells well away from the trabeculae. So we've got some ellipse. We've got left shifted myeloid cells. Not much in the way of full myeloid maturation. Not many neutrophils. You've got some maybe in this area here. Quite a lot of eosinophilia. We've got more eosinophils like here and here, here and here, and scattered around these areas here. Megakaryocytes, actually difficult to see on the H&E. That's always a bit of a clue because you often think then, oh, are there lots of micromegakaryocytes that can be difficult to see on the H&E? There's a megakaryocyte. So we can look at the CD61. So when you're thinking about myelodysplasia, so, an elderly person with a slightly hypercellular marrow and a peripheral cytopenia, myelodysplasia is definitely something to think about. And CD61 is really helpful because it will identify clusters of megakaryocytes nicely and also identify micromegakaryocytes very well. So you can see that we have got clustered megakaryocytes like here. We've got some micromegakaryocytes down here. And there are other micromegakaryocytes here and here, here and here. So that is consistent with the myelodysplasia. So micromegakaryocytes are a relatively strong indicator of myelodysplasia, like here and here. And then more clusters of megakaryocytes. So in these cases, it's important to work out what the blast count is. And to do that, we need to, again, do immunos. We can look at the H&E, but it's very difficult when you've got so much left-shifted myelopoiesis to determine which ones of these immature cells are blasts and which ones are just maturing myeloid cells. So in here, I think that might be a blast there with a prominent nucleolus. Maybe that one there. The rest, I think, are part of a maturation spectrum. The immunohistochemistry here. This is CD. Let's just a good section. Yeah, that's it. So this is CD34, and this clinches it because There's no way you should have this number of CD34 positive cells. You should have maybe just one or two at all in normal to find. So we've got tons of CD34 positive cells. I think it was estimated by my colleague at between 10 to 15% of the cells overall. If you focus just on the positive cells, it always looks more. So you really have to look at the negative cells and then think how many negative cells are there for every positive cell. So I think there are probably around about 8 to 10 negative cells for every positive cell, which gives a percentage of about 10 to 15% positivity. But there's lots of myeloblasts. So this was diagnosed as myelodysplasia with increased blasts, IB2, because the number of blasts was over 10. In the international consensus classification, this would just be called myelodysplasia stroke AML. So obviously formally in the WHO, this doesn't amount to acute myeloid leukemia. But obviously this patient is progressing. So they've had, some anemia in June, nearly 3 years ago. Then they developed myelodysplasia, but that was stable. And now it was previously myelodysplasia with increased blast 1, and now it's gone to myelodysplasia with increased blast 2. So this is going to transform to acute myeloid leukemia. So it makes sense to treat it as such. And so there is a reason to call it myelodysplasia stroke AML, as the international consensus classification would do. The other immunos, I'm not sure about CD117. Yeah, CD117 is also strongly positive. Now, you've got to be careful because a lot of these might be mast cells, actually. I think this CD117 is pretty much all mast cells. Because they're very dense. I think that's probably a blast, but these other cells are spindle-shaped mast cells. Blasts positive for 117 tend to be pale, so I think these will be 117 positive blasts, these ones here. These ones down here. But all these other ones, most of these are going to be mast cells. Okay, that's that case. So my colleagues got quite a lot of these myelodysplasias that he's put aside. I'll do a couple more myelodysplasias, then I'll move on to some plasma cell lesions. So the next one is an 88-year-old man who, again, has got a mild cytopenia. So this one isn't really even a cytopenia. So his hemoglobin's 100, so that's a little anemic. His platelets were normal, they're 209, and his neutrophils are 0.5. So he's got a bi-lineage cytopenia. Low hemoglobin and low neutrophils, but platelets normal. Let's look at his marrow. So, yeah, this is interesting. Very patchy, isn't it? So, we've got some connective tissue. Yeah, looks like muscle. Yes, we've got some connective tissue at one end, a very hypocellular marrow. Now, obviously, within the bone marrow, you can get reduced cellularity in the subcortical region. So this area here can often be hypocellular normally, but it's extending quite a long way out into the marrow. But then as we go out, the cellularity begins to increase. And then at the end, the cellularity for an 88-year-old is actually quite high. So overall, it's reduced cellularity. Now you can get, there's another case of MDS. You can get hypocellular MDS, but even though this patient has got hypocellular marrow overall, this isn't a hypocellular MDS because in that, the dysplastic cells are distributed evenly through a low cellularity marrow, whereas this one has unusually got a very hypocellular area and then a normo to hypercellular area at one end, which is quite unusual. Anyway, within this area, what have we got? Looks like we've got quite a lot of erythroid actually. It's just, yeah, I think a lot of this is all erythroid. Yeah, so erythropoiesis is markedly increased. That's this area here. Let's see. So we've got these large, slightly discohesive erythroid islands, got erythroid left shift. These are left shifted erythroid cells. The megakaryocytes look abnormal. This is probably a micromegakaryocyte here. A slightly abnormal hyperlobated megakaryocyte. Myelopoiesis looks relatively scanty compared to erythropoiesis. It's got some left shift. I think these are left shifted myeloid cells, though it's got more maturation than the previous case we've just seen. But again, we've got dysplastic disrupted erythropoiesis here with discohesive erythroid islands and single erythroid cells lying out on their own, like these two here, this one here. And again, on the H&E, difficult to spot megakaryocytes. We have another megakaryocyte here. I think this may be an atypical a micromegakaryocyte. This looks like an atypical megakaryocyte here. And that might be a micromegakaryocyte as well. And again, we've got dysplastic erythropoiesis. These will be immature erythroid cells here, next to some maturing erythropoiesis, but not cohesive. So little cells wandering off on their own, like that one there and that one there. The erythroid islands, when they're normal, are really quite tight, and the cells are quite tight in against each other. So another hypercellular marrow, a bit hemorrhagic, which makes it a bit difficult to interpret. And the immunos, I think the CD61. So as I said, there's always a really good and helpful stain. So, yep, in this area here, we've got lots of small micromegakaryocytes there, down here, and down here. So megakaryocytic dysplasia, erythroid. If we look at the equatorian, it'll show the erythroid islands. And you can see in places there are good erythroid islands, but there are many cells just lying out on their own. Like there's ones here. So there's a high degree of discohesion within the erythroid series. So that's a dysplastic feature. Large numbers of erythroid cells just scattered out on their own, not part of an erythroid island. Looking at the blast cell markers, this is C34. So quite a lot of blasts around there, some scattered through there, a couple there and there. So again, far more than you expect in a normal marrow, which should have hardly any, if any. But here we've got quite a high percentage, not as high as the previous one. I think this was just considered less than 5%. or just about 5%. Again, CD34 positive blasts there. So diagnosis, the previous one was mild dysplasia with increased blast 2. This one, mild dysplasia with increased blasts 1. There. This one. Uh, so there's a 53-year-old woman. Very interesting. So I think it's moderately hypercellular for her age. It's an adequate to find sample. The peripheral blood, so she was mildly anemic, hemoglobin 119, so that's only just under the bottom end of the range for woman. White cells 2.3, platelets 94, and neutrophils 1.4. But she's also had in the past a thrombocytosis, and she's had a MPL mutation on a myeloid gene panel. So what we have here is quite a markedly hypercellular marrow. We've got relatively large, slightly discohesive erythroid islands here. Myelopoiesis is reduced and difficult to see, in fact, in the background, because what we have mostly, here we've got some myelopoiesis here probably, and a lot of erythropoiesis like here. But we've also got these markedly increased and clustered, almost forming sheets of megakaryocytes. So a really huge megakaryocytic proliferation with a history of previous thrombocytosis and a MIPU mutation. So you might be thinking of ET because of that. But now she's got a mild anemia. Her platelets have dropped now to 94, and she's also mildly neutropenic. So if you look at the CD61 in this case, yeah, I mean, that is tons, isn't it? There's lots and lots. So this was considered to be a myeloproliferative myelodysplastic overlap syndrome. The reason being that she's developing some cytopenias, but it comes from a background of probable myeloproliferative neoplasm, probably with a thrombocytosis and with a MIPL mutation. So it's a MDS MPN overlap syndrome. Also, it looks at the blasts here as well. And there were high numbers of blasts. So again, that pushes it more from the myeloproliferative into the myelodysplastic syndrome. So that's why they've called it a proliferative myelodysplastic overlap because we have a lot of dysplastic features here, both in the peripheral blood count, but also the increased blasts. And you can see all these 34 positive cells in the background here. Well, small case, ignore that one. Right, we've got a couple more cases and then I'll move on to the myelomas. So this one, let me just bring it up. Okay. So a small biopsy. And technically you'd say that this was suboptimal. But the thing is, it's optimal. It's adequate for the diagnosis that's been asked of us. So you have to kind of, when you say something's inadequate, it may be inadequate for diagnosis of lymphoma or myeloma, which are often very patchy. But I think in this case, where we've got all of the marrow completely occupied by just blasts, it's adequate for the purposes, for sure. So what we have here is a small sample. This is from a 65-year-old man. And this is, he was diagnosed with AML, acute myeloid leukemia. He was NPM1 positive. He went into, he was minimal residual disease negative after cycle 1. And after 3 more cycles, and then he had a blood film, and they were concerned about relapse, so they did an aspirate and a marrow, and this is the trephine, so it's almost maximally hypercellular, and all the cells look the same, all kind of like medium-sized, prominent nucleoli, a finely stippled chromatin, irregular nuclei, and a small amount of eosinophilic cytoplasm. So this is full of blasts. So this is relapsed acute myeloid leukemia. The interesting thing about this case, obviously all these cells are blasts. There's just blasts absolutely everywhere, and they all look similar to each other. But on the immunohistochemistry, there were looked like there were 2 different populations. So if we looked at C34, we'll find it. Yep, C34. It's control. So you can see, let's see. There are focal positive C34 positive cells, like in this area here, but the vast majority are negative. And And myeloperoxidase, I think, matches the 34. So again, this shows it quite nicely. You've got distinct populations of cells. You've got some which are myeloperoxidase positive, and then others which are negative. And the negative area are likely monoblasts. So we did staining for CD33 and CD4, and all the cells are positive for that. So in essence, the final consideration was that this was an acute myeloid leukemia in places showing monoblastic differentiation and losing CD34 and what's the control? Losing CD34 and losing myeloperoxidase positivity, if I can find. Where on earth is it? Such a small sample. Sorry about this. And they've put it in the wrong part of the slide. Yeah. Okay, so we've got 33 is expressed everywhere. Myeloperoxidase focal, and it's negative in the more monoblastic areas, but all the cells are positive for 33. So it's it's all acute myeloid leukemia, but with some areas showing more specific monoblastic differentiation. Whether that have indications for treatment or not, I'm not sure. I don't think it's going to change their treatment, but it might be why it's relapsed after disease. Another case that my colleague has left me. This was a bit harder when I'm dealing with ones that my colleague has given me. So yeah, just give it a bit of a clean. So a 65-year-old man who presents with a pyrexia of unknown origin. He's becoming cytopenic, so hemoglobin 66, that's pretty low. Platelets 122, so a little bit low, and white cells 1.9, so that's low as well. And he's got a high per-se marrow, so thinking about a possible myelodysplasia. So it looks like there may be some fibrous tissue in the background in this marrow. We check the retic. So the retic is increased, markedly increased, at least grade 2 and maybe grade 3 WHO scale. Yeah, I think that's grade 3 there. So we've got, I'm not sure how well it projects on the screen, but yeah, for instance, here we've definitely got this purple tinge in the background. There's a bit of purple tinging here. So that's increased reticulin plus collagen fibrosis. You can see it nicely here as well. So we've got increased reticulin grade 3. Like I say, you only really see that in myelofibrosis or metastatic carcinoma. In this instance, the person has a history of myelofibrosis. Excuse me. And then the cells, all of the cells in the fibrosis are all atypical, look at medium-sized blasts. All of these cells here. All of these cells, which all look similar. So I think this is acute myeloid leukemia arising out of myelofibrosis. So myelofibrosis with transformation to acute myeloid leukemia. Now, normally, quite often, that's to an M7 type, a megakaryoblastic, but we can look to see if it is positive for CD61, and we should make it megakaryoblastic. They don't look like megakaryocytes. So we've got some positivity, and I think that this is probably residual megakaryocytes. But most of the blasts are negative. If we look at E-cadherin, it's an erythroid marker. Got extensive positivity in pretty much all of the blasts. So it was considered that this is a case of probable AML M6 or erythroblastic acute myeloid leukemia arising out of myelofibrosis. I'm not sure I've seen an M6 arise out of myelofibrosis before, actually. This may be the first one I've seen. Like I say, it's usually M7, acute megakaryoblast. So that was that case. Yeah. Sorry, I'm just where I'm up to. I need to put them back in the right places. It's all Christie. That's Christie. Yeah. Yeah, that's right, the older ones. Okay. Those the ones that left me on to. Yeah. Okay, so I'll just finish off with a couple of cases of my own. It's different piles of slides, which I need to keep separate from each other. I need to go back into different places. Not that one. Sorry. Too many slides. This one. Yeah. Okay. So 3 cases of plasma cell lesions of interest. That's quite a good one as well, actually. There's another good one there. That's quite good as well. So I've got 4 good cases. That one, I didn't think that was particularly interesting. That one wasn't either. That one was interesting. Yeah, yeah, that one was interesting. And that one was not interesting. Yeah. Okay, so there's a not interesting ones. Right, we'll start off with the first one. So, patient born in 1953, so 71, man, persistent lymphocytosis, hemoglobin 153, platelets 256, neutrophils 5.1, so it's all normal. Neutrophils may be a bit high. Lymphocytes 13.3. He's also got some splenomegaly. No weight loss or night sweats, no palpable lymphadenopathy. Flow cytometry on his bone marrow showed a peripheral B cell population. And there was also a lymphocytosis in the aspirate. Again, this case shows the value of immunos really strongly. So we've got a good core, reasonable cellularity, maybe slightly high for someone aged 71. And looking at it all the way through, I have to take my word for all the way through because I'm only showing you part of it. But I can't see any lymphocytosis or aggregates of lymphoid cells within this marrow. There's some erythroid islands, like here, other erythroid cells scattered around. Go into higher power to see if we can find any lymphocytes. Is that a lymphocyte? We've got some erythroid cells here. Very difficult to see if there's any any lymphoid cells in this. I'll just show you the immunos. So this is CD20. And that just shows how many there are. So there are tons of these. And even though I know that these are there, and I've looked at high power to try and find them, I can't. So it really shows you the value of immunos to find an interstitial B cell infiltrate. And these have got a different pattern. In some places they're saying aggregates, but in a lot of places they're sinusoidal, like here, and here, and here, and here, and here, and here, and here in particular. So this intrasinusoidal pattern is typical of splenic marginal zone lymphoma. The cells are positive for CD20, for CD79A. I think they were positive for PAC. We didn't do PACs. They were positive for 79A and CD20. They were negative for CD5. There was no increase in plasma cells in this case. So we signed it out as a marginal zone lymphoma based on the sinusoidal pattern of those lymphocytes, which we wouldn't have detected without immuno. Right, 3 myeloma cases, or plasma cell cases rather. We'll start off with this one. So patient born in 1955, so coming up to 70. He's had myeloma. He's on a trial. This is post-cycle 12 of the trial, so quite a lot of cycles. So hemoglobin 126, platelets 197, and neutrophils 4.9. So he's got no cytopenias. The aspirate was insufficient. Nothing on the flow. This is the marrow, so a large amount of blood clot, which we can safely ignore, and 2 pieces of marrow. And looking at the marrow, it's a bit thickly cut, actually. Let's just find a better section. That one's a bit thickly cut. Bear with me. Yeah, that's better. That's much better. So it's suboptimal because there's only 2 small cores, and we're looking to see if there's any myeloma, which can be patchy. And looking at it at higher power, I can see no plasma cells. I can't convince myself there are any plasma cells here. Maybe one here. I think there's one there. So I'll show you the immunos. MUM1. I'll show you the CD138 actually, because it's probably just a bit easier to show in the interest of time, but the MUM1 is the same. So very low numbers of plasma cells. I think less than 5. And they look like plasma cells. So very low numbers, that's a good result. And we need to check that they're not restricted. So this is lambda, and you can see focal plasma cells here. And if we go to kappa, we can see focal plasma cells as well, like here and here and here and here. So no light chain restriction. So this was a good result in this patient. No residual myeloma after the trial treatment. So excellent. The next one, someone born in 63, so 71. Their full blood count was normal. Well, they've got slightly increased platelets, but otherwise their full blood count was normal. But they had a pathological fracture of T11. They've got a raised immunoglobulin paraprotein. And so the question is this myeloma? Well, again, on H&E, can find it. Can't really see any plasma cells on H&E. When I look around, just looks like normal marrow. But if we look at the immunos, this is CD138 for plasma cells. We can see that there are increased numbers of plasma cells. Some of them do look a little atypical here. But again, I'd say probably only about 5%. No more than that. But in this instance, they are restricted. So they are clonal. So it's an interesting case here because I don't know whether you call this a plasma cell dyscrasia or multiple myeloma. Now, the percentage is really low. This is lambda. You can see occasional plasma cells scattered around. If we go to kappa, there are tons more on the kappa. So this area here, for instance, lots and lots of kappa positive plasma cells. So the thing is, if you've got a plasma cell, if you've got end organ damage, like a vertebral fracture, then it's usually considered that it would be called multiple myeloma. But the WHO classification says that you should have at least 10% plasma cells in the marrow, plus end organ damage. This one is under 10% plasma cells, it's only about 5. So I've said that, the appearances of those are plasma cell dyscrasia and maybe multiple myeloma dependent on clinical features. I think in essence, this is multiple myeloma because we have got a vertebral fracture and a raised immunoglobulin, but the plasma cell percentage in the bone marrow in the spine is too low. And it was also less than 5% in the aspirate. But I think that they will treat this patient as a multiple myeloma because there is already end organ damage. Like I say, if the plasma cells were higher, if they were 10%, I would just call this multiple myeloma anyway, because we've got 10% plasma cells plus end organ damage. And the final case is another post-trial patient for myeloma. I'm afraid this one is a bit easier than those two. So those last two were good examples of a low percentage of plasma cells. One was not neoplastic and the other was neoplastic. And in fact, probably multiple myeloma. So this one is after the radar trial. And here if we look carefully, these cells don't look like normal hematopoietic cells. We can see plasma cells quite easily in here, lots of plasma cells. And in fact, in this one, there was 60% plasma cells. So there was no, and the previous biopsy had been 60% as well prior to the trial. So unfortunately, this patient, there was not a good result at all. And this is the CD138. You can see large numbers of plasma cells. And of course, these are restricted. Okay, I'll stop there. That was a bit of a run through of lots